Hello, everybody. My name's Megan Fix. I'm coming to you from the University of Utah, and we are going to talk about subarachnoid hemorrhage and other thunderclap headaches. So let's get to it. I have no disclosures, and I want you to first think, what actually is a thunderclap headache? It should be like this. A thunderclap. So when I think about thunderclap headache, I want you to really think about the history that your patient tells you. And for example, I had a patient one time that came to me and said, I had the worst headache of my life. I was reaching for a gallon of milk at the store, and all of a sudden, boom, your thunderclap. That should be telling you that something bad is going on. Now, when we hear that in medicine, we always think, subarachnoid hemorrhage. Subarachnoid hemorrhage. Any thunderclap headache is a subarachnoid hemorrhage until proven otherwise. And that is for good reason, because the patient behind door number 3, if they have a subarachnoid hemorrhage, their mortality is high. And it is a very deadly diagnosis. So that's why we've always been taught to think about subarachnoid hemorrhage as a thunderclap headache. But what I want to impress upon you today is to actually think that there are other things that could cause a thunderclap headache that you should be thinking about in addition to subarachnoid hemorrhage. So behind doors 1 and 2, we are also going to talk about 2 different diagnoses that can present with a thunderclap headache. You take a good history, you do good physical, and I promise that you can figure out yes or no, do they have a subarachnoid hemorrhage? But also, do they have something else when your patient presents with a very sudden, severe headache, otherwise known as a thunderclap headache? So today we're going to cover 3 different diagnoses. We're going to dive deep into subarachnoid hemorrhage. What's new? What's happening? How do I diagnose and treat this condition? Because it is the most important thing to think about when you hear thunderclap headache. But we're also going to talk about 2 other diagnoses. RCVS, reversible cerebral vasoconstriction syndrome. You may have never heard of this, but my goal is by the end of this talk that you will know about this diagnosis and think about it, and maybe even diagnose it yourself in your next patient with a thunderclap headache or multiple thunderclap headaches, and we'll talk a lot more about it. And then finally, a rare diagnosis, cerebral venous thrombosis or CVT, which can also lead to thunderclap headache. Now, there are many other things that could cause a headache in the emergency department, including a dissection, meningitis, a migraine, a tension headache. We don't have time to cover all of those, but I'm going to give you some great resources and some good articles that can help familiarize yourself with what could be happening in your patient with headache. So let's talk about headaches. They cause a lot of headaches for us as emergency providers because we see a lot of headaches. Headache makes up 2% of all ED visits. Now, of all those headaches, only 2% of those is subarachnoid. But let's talk about our thunderclap headaches. When the patient says, I was reaching for the gallon of milk and all of a sudden I had this headache. Of those, subarachnoid hemorrhage is 10%-ish. That's kind of the classic thought. So that's a significant amount, and that's why we always work up subarachnoid hemorrhage in patients who come in with thunderclap headache. But RCVS, classically RCVS, and I'll tell you more, was thought to be about 6% of those patients, and then CVT is much less, around 1%. But they're all in the differential. So first, we're going to talk about the bad one, subarachnoid hemorrhage. And there's actually 2 types of subarachnoid hemorrhage. So subarachnoid hemorrhage just means that there is blood in the subarachnoid space. But there's 2 flavors here. There is aneurysmal, which is the bad one when an aneurysm bursts, and then there's non-aneurysmal, which is actually thought to be venous bleeding, and then that blood gets into your subarachnoid space. 80% of patients actually have the bad aneurysmal subarachnoid hemorrhage. You'll see here lots of blood coming from an aneurysm all over, causing lots of mass effect and cerebral edema and other bad things. But 20% of patients with subarachnoid hemorrhage are this non-aneurysmal, which is much less blood, and in general, these patients do really well. Aneurysmal subarachnoid hemorrhage is bad, high mortality, whereas non-aneurysmal, 20% of those patients actually do really well. But they're still subarachnoid hemorrhages, so all these folks need to be seen by specialists in neurosurgery. So again, aneurysmal subarachnoid, this is the bad actor. This is when an aneurysm bursts and spews blood into your subarachnoid space. And I really like this image because it conveys how serious this entity is. You can see the aneurysm there that someone's probably been walking around with for a long time. It bursts and it spews blood cells into your subarachnoid space. Now, it can cause mass effect, edema, all these other just localized problems, but actually down the line, the blood in that subarachnoid space can lead to vasospasm, which can actually be very detrimental for the patient when they're admitted in the ICU. Alternatively, 20% of people with subarachnoid have these non-aneurysmal, perimesencephalic is the other way we say this, and those subarachnoid hemorrhages are much more forgiving, and most of these patients do really well. So when I was in training, anytime a patient came in with a thunderclap headache, you always did a CT followed by an LP. If the CT was negative, it was a sentence, CT, comma, LP, period. There was no CT, period. But in 2024, we've come a long way in the diagnosis of subarachnoid hemorrhage, and most of you know that if you do a CT scan with a radiologist, a modern-day CT scanner, the patient's normal mental status, and you do it within 6 hours of the beginning of their symptoms, you are good. You have ruled out subarachnoid hemorrhage. We call that the 6-hour rule. So we're not doing as many LPs for this anymore. But what are the guidelines saying? What's the updated evidence? Let's go through that so you can feel good about using this approach. So we're going to talk mainly about 2 different guidelines throughout this lecture. The AHA, or the American Heart Association, stroke guidelines came out in 2023. And this is the top paper. This is really focusing on aneurysmal subarachnoid hemorrhage, okay? These are the guidelines for aneurysmal subarachnoid hemorrhage. Then ACEP, the American College of Emergency Physicians, also put out guidelines for the management of patients with acute headache. This was in 2019. Both of these are excellent documents, and I'll go through the evidence and what these guidelines say that can help you inform your patients. But first, let's talk about why, back in the day, we all did a CT scan followed by an LP. Why did we actually do this? Well, let's say it's time 0 right now. I'm reaching for the milk and boom, I have a subarachnoid hemorrhage. If you CT scan my head right now, you'll notice blood is bright. Acute blood is bright on CT scan. So you'll see that blood on CT is very visible early on, but the ability to see that blood goes down over time because the blood becomes isodense on your CT scanner. So that's that arrow where the blood is not as apparent on the CT scan as time goes on. However, when you do an LP, let's say you did an LP at time 0 right when I had my subarachnoid hemorrhage, the CSF fluid would be pretty clear, and it takes time for the blood, the heme that's in the CSF to kind of discolor the CSF itself. So the CSF goes from clear to more of a yellowish tone. That is called xanthochromia. So when you do a lumbar puncture, you're looking for xanthochromia as an indicator that blood has been there. And xanthochromia gets more visible over time. So there's this inflection point somewhere, and the classic teaching was that if you don't see a subarachnoid hemorrhage on your CT, you have to do the LP to make sure you're not missing it through that timeline. And I'll show you an example of why that is for the CT scan. So here's acute blood. You see is bright white. This is actually a subdural, but it highlights exactly what we're talking about. Acute blood is bright white. Subacute blood, you'll see, is less bright as it's becoming more and more isodense, and then chronic blood is really indeterminate. So you'll see it's difficult to see blood that's old on a CT scan. Conversely, when you're looking at your lumbar puncture, your CSF fluid, you'll see that xanthochromia, that yellow discoloration of the CSF, is more apparent later on. So people started thinking, well, should we really be doing all of these LPs? LPs are time-consuming. Post-LP headaches are quite common. Up to 20% of patients who have an LP have a headache that's worse afterwards. And then there's these equivocal results. You've all had that where you do a lumbar puncture, there's blood there. Is it blood because the puncture itself was traumatic, or there's their blood there because there's a subarachnoid hemorrhage. That leads to automatic admission, neurosurgery, much more workup for the patient because you just don't know. So people started thinking, very smart people started thinking, well, is there another way that we can work up this very deadly diagnosis of subarachnoid hemorrhage? Is there a decision rule? The answer is yes. Can we use CT alone? The answer is also yes. That's the 6-hour rule. Can we use a CT angiogram? The answer is also yes. And can we use an MRI? The answer is maybe. It's not in the guidelines, but MRI is also another modality that you could use. So the history here, let's go back to the great country of Canada and the great city of Ottawa, where Dr. Jeff Perry and friends did a lot of work on subarachnoid hemorrhage. Just an amazing group, and have given us really, really awesome evidence to work with. So Dr. Perry and friends developed the decision rule, the Ottawa rule for subarachnoid hemorrhage. And you can find this many places on the internet, but essentially if your patient has any of these 6 things, they fail the rule and you must work up subarachnoid hemorrhage. Conversely, if they don't fail any of these 6 things, then it is very, very unlikely that your patient has a subarachnoid hemorrhage. So the things are age greater than 40, neck pain or stiffness, think of that as like someone who has meningismus, witness loss of consciousness, onset during exertion, thunderclap headache, just like we talked about in the beginning, where the headache is maximal intensity right away, and then limited neck flexion on exam. Limited neck flexion. So this was very sensitive. It was externally validated. This is a good rule. The problem I find with this rule is that most of the patients that come in that you're worried about, they already fail this rule, right? Anybody with a thunderclap headache is going to fail this rule. But I really like to use this for our trainees, for learners, medical students, and residents, because these are the features that I want you to ask about during your history that gives you the sense for how high risk this patient is. So the Ottawa subarachnoid rule is quite good. It's just that most of the patients you're already worried about are going to fail this rule, but really good for trainees. Just for funsies, what of those 6 things was actually the most sensitive? Well, it's actually neck pain or stiffness. And if you think about it, that makes sense because when the blood spews out into your subarachnoid space, it's very irritating to the meninges to have blood there. Just like in meningitis, it's very irritating to have all those cells there in meningitis. So if you have a patient who comes in, they have a very severe headache and they're really having a lot of neck stiffness, be worried about subarachnoid hemorrhage or meningitis or encephalitis, because that's very irritating to the subarachnoid space, the meninges. So remember back to our guidelines, the ACEP guidelines do endorse the Ottawa subarachnoid rule. So they do endorse using this rule. So know that it is a good, very solid rule for working up a subarachnoid hemorrhage patient. Okay, so we have a rule. What about just the CT? So remember we talked about this inflection point where the blood that's very bright gets worse and worse in terms of your diagnostic ability, and then the xanthochromia gets better and better over time. Well, it turns out that this inflection point is around 6 hours, and this was from, again, some very good work on part of Dr. Perry and friends, and this was the landmark paper. This came out actually in 2011, so this is over 10 years ago, and it really helped us work up these patients better. And essentially what they found is they did CT scans on all these patients who came in with headaches. They ended up having 240 with true subarachnoids. And their definition, just so you know, of thunderclap was peak intensity of headache within 1 hour, which is probably going to capture more patients. And what did they find? Well, they actually found the CT sensitivity to find subarachnoid hemorrhage was 100%, as long as you did the CT scan within 6 hours. So this is the 6-hour rule. This is the landmark paper from the BMJ that started us talking about the 6-hour rule. Notably, the sensitivity for CT scan after 6 hours was much less, only 87% in this subset. So after this time, this was 2011, many people wrote articles, subsequent articles were done, people discussed this. And what ended up happening? Well, where are we now? This rule is endorsed by both of the guidelines that we discussed, and I'll show you the language here. So the AHA stroke guidelines do say that you can totally use the 6-hour rule. They say here that in a patient with acute onset of headache, less than 6 hours of ictus, a non-contrast head CT is a reasonable to diagnose or exclude aneurysmal subarachnoid hemorrhage. Remember, that paper is really about the aneurysmal subarachnoids. What does the AHA say after 6 hours, you might ask? Well, the AHA after 6 hours recommends LP. If your non-contrast CT is not diagnostic, they say that you should do a lumbar puncture to exclude subarachnoid hemorrhage. So this is important to know. If you're really worried about an aneurysmal subarachnoid hemorrhage, the AHA says that you should do an LP as your next step. What does ACEP say? Well, ACEP also loves the 6-hour rule. You'll say in these 2019 guidelines, ACEP says here that if you do a CT scan within 6 hours and the patient has a normal neurologic exam, you can rule out non-traumatic subarachnoid hemorrhage. So ACEP also loves the 6-hour rule. So you can feel very confident that if you do your CT scan within 6 hours by both of these guidelines, you are good to rule out aneurysmal subarachnoid hemorrhage. Now later on, we're going to talk about what else could be going on, but at least you can rule out the aneurysmal subarachnoid hemorrhage. So you may be thinking to yourself, what does ACEP say I should do after 6 hours? Well, interestingly enough, ACEP says you can do the CT angiogram or the LP. You'll see here in yellow, ACEP says perform LP or CT angiogram to safely rule out subarachnoid hemorrhage in ED patients after 6 hours. So think on that for a moment. You have a lot of options, and I'll tell you my approach to this is doing a good history and physical and thinking about what do you really think is going on to help you with that next step, and use shared decision making. And we'll talk more about this. So this was the evidence we really had for a long time. Then this study just came out in 2024, and it helps me think about this concept because we have been using this 6-hour rule for about 10 years or so. And so 6 hours, we feel very confident that it is a very high sensitivity to rule out subarachnoid hemorrhage. But what happens after 6 hours when you do the CT? If the patient comes in at 6 hours and 10 minutes, is the CT scan total crap? Well, actually, no. This is a study from the UK where they took a bunch of patients, a large prospective observational trial, and they calculated the sensitivity of CT going out in these different hour ranges. Less than 6 hours, it was still very, very sensitive. Not 100, because nothing's 100 in medicine, but it's 97% sensitive to rule out aneurysmal subarachnoid hemorrhage. But what you'll see here on this study is that between 6 hours and 18 hours, CT is not total crap. It's actually still quite good. It's 94% sensitive all the way up to 18 hours. Now, this needs to be redone and validated in future study, but I think it can give you a sense when you're doing shared decision making with your patients that actually a non-contrast CT up to 18 hours is still very good with a sensitivity of 94%. So that makes me feel better that the sensitivity doesn't just fall off a cliff after 6 hours, but once you get over 18 hours, it kind of does fall off the cliff. Only 75% sensitivity when you're after 18 hours. So a lot of folks have been talking about CT angiogram to work up these patients. CT angiogram is a great test, but I want you to understand, what does it look for? Non-contrast CT, as we showed, looks for bright blood. CT angiogram is looking for vascular structures and aneurysms, okay? It doesn't do better looking for blood. It looks for aneurysms or dissections or vascular structures. Now remember, we're going to talk about RCVS in a little bit. CT angiogram is actually the best test to look for RCVS. So CT angio has a lot of really great things about it. It can really help us make diagnostic decisions. But there's a downside with the CT angiogram, and it's this. 2 to 3% of us are just walking around with aneurysms that we don't even know about. So your CT angiogram may find one of these asymptomatic aneurysms, and then you have to determine, well, is the headache I came in with caused by this aneurysm or not? You don't really know until you do a bunch of other tests. So what happens is you find these aneurysms, the patient ends up getting referred to neurosurgery. They may end up having a surgical procedure that could cause complications such as stroke or death, and also it's stressful. So this is the problem, is that you will find things on the CT angiogram, but it's unclear what to do about that information. And some patients may really want to know. I really want to know if I have an aneurysm because my uncle had one. And some patients may not. So that's where, again, shared decision-making is very important. Now, remember I said CT angiogram can show us lots of other things. So let me give you an example of that. Here you see on the left, CT angiogram showing an ACOM or anterior communicating artery aneurysm. Bright white, it's lit up right there for you. That's really important to know about. But on the right, you'll see something called RCVS, reversible cerebral vasoconstriction syndrome. I'm going to highlight what you're looking at. This right here, see how that artery right there has little beads or sausages on a string, sometimes people call it. What's happening there is actually vasospasm in the artery itself. That is what's leading to the headache. So doing a CT angiogram can actually really help you diagnose RCVS. And for foreshadowing for later, a CT venogram can actually help you really look for cerebral venous thrombosis, which we'll also talk about. So it's understandable that a lot of folks are ordering CT angiograms because it gives you a lot of information. Now, what about the MRI? Well, MRI actually also can look for blood in the subarachnoid space, and MRI is actually better as time goes on. Showing you an example here, this is a patient that they did a CT scan and an MRI the same day, very similar times, and you'll see the CT scan does not show the 5-day-old subarachnoid hemorrhage, but the MRI, same time frame, shows the subarachnoid hemorrhage right there. So if your patient is, again, very far out from the ictus of their headache, you may want to consider doing an MRI. Now, MRI can also see tumors and seizure foci and many other things. So depending on your history and physical, you may want to do an MRI. So where does this leave us? Well, we have great evidence and good guidelines telling us that if a patient comes in with your thunderclap headache, you're worried about subarachnoid hemorrhage, as you should be, you can do a non-contrast CT within 6 hours and feel good to diagnose or exclude subarachnoid hemorrhage. But after the 6 hours, you have to do something else. That something else could be a lumbar puncture based on the AHA guidelines, but also if you're really worried about aneurysmal subarachnoid, it will show you xanthochromia if it's there, or it may show you meningitis or encephalitis if that's what you're really worried about. You can also do a CT angiogram. That's endorsed by the ACEP guidelines. And you may want to do that if your patient says, I have a family history of aneurysm. I really want to know if I have an aneurysm. Or if you're worried about RCVS or something else vascular, such as a dissection. So where this leads us is shared decision-making. And this is really cool. This is the art of medicine, where you do a good history, you do a good physical exam, and you talk to your patient about the pros and cons of these different tests. And now that you know the pros and cons, you can make informed decisions with your patient about what is best for them. But just know, after 6 hours, still based on the guidelines, you need to do something else. That something else, you're going to use your good history and physical and talk to your patient to determine what that is. The AHA says the something else should be a lumbar puncture. ACEP says that you can use either a CT angiogram or a lumbar puncture. And I really like how the ACEP guidelines go on in this slide to show us, again, use shared decision-making. They're even telling us to use shared decision-making with the patient, and you should put that in your note, that you talked to the patient, you went over the risks and benefits, the pros and cons, and we decided to do this using shared decision-making. And that can be very powerful because it's in the guidelines. Just for your reference, I put up all the actual language from the guidelines. Here is what the AHA says about why they chose to use LP as the next step in patients who present after 6 hours. This is the language from the ACEP guidelines saying, again, that they recommend you can do either a CT angiogram or an LP to, again, rule out subarachnoid hemorrhage. but you do have to do something else after the 6 hours. This is the schematic from the AHA guidelines, just showing you again that they do recommend here lumbar puncture, but they do still recommend a CTA if you've actually had a positive CT or if you had a diagnosis of subarachnoid. So know what the guidelines say, know your options, and then let's say you found it. You found a subarachnoid hemorrhage. What are you gonna do now? We spent all this time talking about how to make the diagnosis, but what do we do when we've made the diagnosis? Well, there are a few things that are very important for us, but most of the treatment is done by neurosurgery. In the ED, I want you to really focus on the blood pressure. That is paramount. Blood pressure control is super important. Remember the blood spewing out of the aneurysm? You want to control the blood pressure. Guidelines say to get the systolic blood pressure below 160, but most neurosurgeons would say go to below 140 if your patient can tolerate it. In order to do this, you need a very quick-acting, titratable IV agent such as nicardipine or labetalol. You can also use clofidipine if you have that available to you. Really important though, you don't want to drop their blood pressure so low that they become hypotensive because that will decrease your cerebral perfusion. You want to perfuse the brain, you just want to keep that systolic below 160 or 140. So use those agents, clofidipine, nicardipine, or labetalol. That's number one, blood pressure control. Number two for us is anticoagulant reversal. If your patient is on warfarin or they're on a direct oral anticoagulant, you got to get them reversed quickly. My best advice for you in this scenario is to look to your hospital guidelines, your hospital protocol, because there's a lot of nuance here and certain hospital systems will like something over the other. But for the most part, if it's a warfarin, you're going to do IV vitamin K plus 4-factor PCC. If it's a DOAC, you're going to generally use 4-factor PCC. Some people are using andexanet alpha, but I want you to talk to your local folks to figure out what you're going to give, but you are going to give it fast. And then number three, all these patients need a neurosurgery consult. So that may mean you need to transfer the patient to an academic center, and you definitely want to get them in the ICU. And that's really most of the treatment that we're going to do in the emergency department. There are some special things if you have to intubate the patient, you want to keep their head a bed up, some other things to think about if you do have to intubate them. And then there are a lot of other things that happen once the patient gets to the center with the neurosurgeons. The guidelines from the AHA go into a lot of detail about this, so if you are a referral center, you may want to look into these. But the basics are that they want to get the patient to a stroke center as soon as possible. They talk about the Hunt and Hess scale, which I'm going to show you in a moment. There are bundles for the ICU they recommend. They want you to maintain euvolemia. If the patient seizes, then you give them anti-epileptic drugs, but only if they seize. And then they also talk about giving oral nimodipine. Now, this is to prevent that vasospasm from the blood over time. I want to spend a minute talking about the Hunt and Hess grading scale because you may get asked about this when you're calling your neurosurgery colleagues. Now, this is a scale based on your patient's presentation, how severe they are when you see them, and their mortality. And just note, if your patient is a grade 1 and they have a mild headache, no neurological deficits, their survival is pretty good, 70%. But if your patient is a grade 5, where they're in coma, or they're posturing, their survival is very poor. So know where to find this. It's on all the interwebs. But if your neurosurgeon asks you about this, have a sense for what their Hunt and Hess grading scale is, because that is very helpful for surgery planning. So to summarize, aneurysmal subarachnoid hemorrhage. This is the bad actor. When your patient comes in with a thunderclap headache, you've got to think about this. Know that we do have a rule, the Ottawa subarachnoid rule, and if you fail any of the 6 things, you must work this up. Know that we also have the 6-hour rule from Dr. Perry and friends. This is now endorsed by both the AHA and ASEP. So you can feel good that if your patient comes in with 6 hours, very severe headache, you do a non-contrast head CT and it is negative, it essentially rules out subarachnoid hemorrhage. But I want you to also think about what else it could be. We'll talk about that in a moment. If your patient comes in after 6 hours and you're worried about subarachnoid hemorrhage, you have to do something else. The something else can be an LP or a CT angiogram. Use shared decision making and use your knowledge of what those tests are looking for and what you think might be happening to guide you for that something else. So let's talk about the something else's. What else could be causing your patient's thunderclap headache? Let's think about it again. Thunderclap headache. Your patient comes in and they say, I was reaching for the gallon of milk when all of a sudden, boom, thunderclap goes off in my head. What else could be going on? And this is a really important part of this talk because I remember thinking in residency, patient comes in with with a thunderclap headache. It's a subarachnoid. If it's not, you send him home. But actually, a lot of other things could be going on. So what are those other things? Well, this is a really excellent paper by an amazing emergency physician who's an expert in emergency neurology, Dr. Jonathan Edlow. I highly recommend you check this out because he goes in detail through all the different possibilities of a severe sudden onset headache. And this is the flow diagram, and I'm going to point out a few things here. Step 1 is brain CT. We know that. This is the 6-hour rule. If it's diagnostic, you're going to deal with what you find. Subarachnoid, you're going to get them to neurosurgery, etc. If it's non-diagnostic, you decide, is it within 6 hours? If it's within 6 hours, think. Diagnostic stop. I love this. Think about what else could be going on before you just send the patient home saying they're good. Think about your history and physical. Are they pregnant or postpartum? Are they hypercoagulable? Have they had multiple thunderclap headaches or anything else to make you think of a different diagnosis? Now, multiple thunderclap headaches, what should that make you think of? That should make you think of something called RCVS. And that's what we're going to talk about next, reversible cerebral vasoconstriction syndrome. And looky there. What do you do as the test for RCVS? A CT angiogram. So this has actually pushed me into ordering more CT angiograms because I'm seeing more of this RCVS. So we're going to talk about just 2 of these many diagnoses. Again, check out the paper to see more. We're going to talk about RCVS today and cerebral venous sinus thrombosis, or for short, also called cerebral venous thrombosis, or CVT. So remember thunderclap headaches. Of thunderclap headaches, I said classically about 10% were subarachnoids. And some studies show that it actually could be up to 25%, but it's definitely a significant amount. Now, RCVS, classically it's been thought to be about 7 or 8% of thunderclap headaches that come to the ED, but recent evidence suggests that it's actually more than that. Probably because we're thinking about it more. It's a relatively new diagnostic entity. And we're looking for it more because we're doing more CT angiograms. So we're seeing it more. So I want you to know about this diagnosis because that is probably what patients that you have seen who have thunderclap headaches, who don't have subarachnoids, it may just be what they have. So remember RCVS. And then CVT is probably anywhere between 1 and 5% of thunderclap headaches. So behind door number 3 was a subarachnoid hemorrhage, but behind door number 2 is this thing. RCVS, reversible cerebral vasoconstriction syndrome. What the heck is this? Well, what I want you to remember is it is recurrent thunderclap headaches. Multiple times. If your patient has a thunderclap headache that then gets better, then comes back again, then gets better, you gotta think about this. And what is actually going on? It's vasospasm in those arteries. Remember, we saw that a few slides back where there were beads on a string along the CT angiogram, along the artery. It's interrupted because there's vasospasm at different segments. That's what's going on, creating the headache. Most of the time, the headaches will last between 1 and 5 hours. They'll get better and then recur over weeks. And the good news is that in the diagnosis, it actually gets better, okay? It's reversible. But the reason that we're worried about this and by why these patients need to get admitted and get a workup is because there are some bad complications that can occur when patients have RCVS. And these complications can be really sucky, like subarachnoid hemorrhage, seizure, intracranial hemorrhage, press, or stroke. So this is why I want you to know about it, because some patients with this can have those bad complications. So most patients who have RCVS have some kind of historical factor, like history of migraines, history of pregnancy or postpartum, or history of hypertension. But the key hallmark of this syndrome is most of the headaches are triggered. So this is where your really good history and physical come into play, especially the history. If the patient says, I had a severe headache that occurred during sexual activity, that should be a bell going off in your head to think about this. If the patient says, I was lifting weights, I was doing Valsalva, and I had this very severe headache, that should make you think about this. If they were running or exerting themselves and they got an exertional headache, that should make you think about this. Showering. I had a patient who said, I was showering and all of a sudden I had this severe headache, or bending over. I've highlighted 4 things in yellow because in the last 10 years of giving this talk, I have seen these 4 different patients with this diagnosis. One was postpartum, one was having sexual activity, and then one was having exertion, and one was showering. So it's out there. Now, the other really important trigger is vasoactive drugs. Remember we said RCVS, vasospasm of the cerebral arteries? Well, certain drugs can be very vasoactive, such as marijuana, cocaine, methamphetamine, serotonergics, or triptans. So this is from a recent review paper about this diagnosis. If you're interested, I highly recommend you check it out. But the clinical characteristics are, again, thunderclap headaches, and it can be recurrent. Cerebral vasoconstriction in 2 different arteries. It's multifocal, those beads on a string, vasoconstriction in the arteries. And then in the definition, it should resolve within 3 months, which is good. The precipitants, there's a bunch of drugs listed there. And then the complications is why we worry about this diagnosis. As you see there, again, people can have PRES, subarachnoid hemorrhage, intracerebral hemorrhage, stroke, or seizure. So how do you make the diagnosis? Well, person has to come in with a severe acute headache, thunderclap headache, plus or minus neurosymptoms. Sometimes they don't have neurosymptoms. And then you're gonna do some kind of angiography, because this is, again, a vascular vasospasm of the cerebral arteries. So generally, CT angiogram is the preferred test. Most of us have access to this now. Remember, CT angiogram also looks for aneurysms, so that's why a lot of folks are going to do CT angiogram to look for both aneurysms and RCVS. And this is the test of choice. You can also do an MR angiography or traditional angiography to make this diagnosis. Notably, early on in the syndrome, your imaging might be negative. And that is something that is super tricky. We're just going to leave it at that for now. But it might actually be negative, and you still could have the diagnosis. And then remember, it's reversible within 3 months. There's actually a score now, an MD Calc, that you can go to if you have a patient and you think it might be RCVS. And you'll see here, recurrent or single thunderclap headache gives you 5 points. That's the most important thing, the history. And then you're going to do some kind of so you're going to do a CT angiogram. And if it's in the carotids, it's actually not as likely to be RCVS, but be that as it may. Vasoactive trigger gives you 3 points here. So do that good history and ask about drug use. And then being female gives you a point. And then if you have bleeding on imaging, it gives you a point. So this has actually been validated, and it's a good score to use to help you learn about the syndrome, but also if you're worried about a patient having this. So again, what do we see in RCVS on the CT angiogram? Well, this beating of the intracranial arteries is the hallmark. And see how it's present in multiple different arteries and is all along looking like a sausage on a string, is sometimes what the radiologist will refer this to as a liking of this. So again, beating or sausage on a string of the cerebral arteries on your CT angiogram is the diagnostic imaging that would suggest RCVS. Here is a patient, remember the patient that I said that was exerting and lifting weights? This is the patient's actual CT scan that I just saw recently. And you'll see here again, CT angiogram, beating of the cerebral arteries. So there is multifocal areas of vasospasm. That is what is happening in RCVS. So let's say you make this diagnosis, what do you do? Well, you're going to call neurology because this is still a very interesting syndrome. Again, there's all those complications we worry about. So you're going to call neurology and admit the patient. You're going to give them some analgesia because they can have very severe headaches. You're going to have them rest and avoid exertion. and stop any vasoactive drugs that may be contributory. And sometimes these patients do get better with calcium channel blockers or magnesium. But again, in the definition, most of them do really well. But by and large, you're going to call neurology and admit these folks so they can get more workup and treatment. Because there are some severe complications with RCVS, including subarachnoid hemorrhage, seizure, ICH, ischemic stroke, and PRES. This is an example of a CT scan of a patient who had RCVS and then got bleeding. Classically, you'll see the bleeding in these convexal regions, and so that's why we typically admit the patients if they end up having a complication. So RCVS. What's the take home? Number one, I want you all to remember that there is this thing. Even if you don't remember exactly what the words mean, just remember that there was this thing, RCVS, thunderclap headaches, multiple thunderclap headaches that are caused by vasospasm in the cerebral arteries. You do a CT angiogram to diagnose it, and you call neurology and admit them. So remember, reversible cerebral vasoconstriction syndrome. Okay. Now that we all know about this, let's finally talk about what's behind door number one. This is the most rare condition that we're going to talk about today. It's cerebral venous thrombosis. This is a great anatomy picture showing you all of the big veins that surround and drain the blood from our brains. Now, if any of these big veins get a clot in them, that's a cerebral venous thrombosis. And the way I think about this condition is a DVT of the brain. It's a deep venous thrombosis. It just happens in the veins around the brain. So all of the risk factors that you think about for DVT are also risk factors for a CVT. They're more common in women. Most of the patients who have this get a headache. Now, this talk is referring to thunderclap headaches, but in actuality, most of the patients who have CVT have gradual headaches. About 30% of them will have a thunderclap, but I want to tell you about this diagnosis so you're aware to think about it. Everybody who has this has some kind of risk factor for hypercoagulability. So again, doing a good history, you're going to pick up on those things just like a DVT risk factor, same as a CVT risk factor. If they're on oral contraceptives, they have cancer, they have a hypercoagulable state, they're pregnant or postpartum, smoking, or recent surgery. Now, this diagnosis is tricky. It's actually often missed on one or multiple visits. And then by the time the diagnosis is made, most of the patients actually have a focal neurologic finding. So the more that you think about this and test for it, the more that you will find it hopefully earlier, because the mortality is quite high. It's 10 to 30%. So this is a really important diagnosis for us to know about. Now, remember I said good history, good physical, or let's say an excellent history and an excellent physical are really important for your workup of patients with thunderclap headache. And physical exam is really important specifically for CVT. In the review article that I talked about, patients had mainly one of these 4 physical exam findings. So I want you to remember this and do these as much as you can in your headache patients. Papilledema. So that's that picture there where the optic disc is coming out at you when you do fundoscopy. Now I know fundoscopy's hard. It's difficult to do. Some of you have those cool cameras that can take a picture of the fundus. If you have that, go ahead and do it. If you don't, try to do a little fundoscopy. You can also use ultrasound to look for the optic disc. But papilledema is present in about 30 to 60% of patients with CVT. So it's an important physical exam finding if you see it. Visual field cuts were also seen in a significant amount of these patients. Remember, you have the patient cover their eyes and you do visual fields. That is a really important physical exam maneuver, super easy, super quick. And if you have a positive on that, you definitely want to do advanced imaging. Some patients had a 6 nerve palsy, so remember you're going to do your extraocular movements. And then some patients had proptosis. So how do you actually make the diagnosis of this? Well, you would think it's a DVT of the brain. Can I do D-dimer? Unfortunately, not yet. There's not enough good evidence to have us feel good about using a D-dimer for this yet. And a CT scan alone can't do that either. A CT scan alone, a non-contrast CT, can miss up to 30% of these as well. There are a few signs, if you see it on a non-contrast CT, like the triangle sign and the cord sign, that suggest this diagnosis. But the gold standard is actually an MRV, MR venogram. And this is a protocol that your radiologist can do to just highlight the veins with the contrast. But if you don't have access to MRV, you can also do CTV, CT venogram. And again, just talk to your radiologist. They time the dye so that they light up the venous system. And I'll show you examples of that. This is non-contrast CT scan. Remember, it's not great, but if you see either the triangle sign where you see bright white blood in that sagittal sinus, or the cord sign when you see hyperdensity as a cord running along that cerebral vein there, the sinus, if you see those, then you have the diagnosis. But 30% of the time, your CT non-con is going to be normal or non-diagnostic. So the CTV or the MRV is really your go-to here. I'm going to show you what it looks like. So a normal CTV over here, remember the veins are opacified with the contrast during the venous phase. So a normal sagittal sinus should be bright white because blood is running through there. In contrast, a patient with a cerebral venous thrombosis, okay, here this is sagittal sinus thrombosis, the sagittal sinus is not showing bright blood running through it. So it's opacified here because there is a clot in the sagittal sinus. So this is a CT venogram, which is a really easy study for most of us to get, as long as you talk to your radiologist, showing that sagittal sinus thrombosis. So if you do diagnosis, what's the treatment? Well, it's a DVT of the brain. So you're going to treat it as you would a DVT with anticoagulation. Heparin or low molecular weight heparin are both reasonable to give. So you can give either. Talk to your neurology colleagues about what they prefer. And interestingly enough, some of these patients with a CVT, a DVT of the brain, actually will have bleeding because of the local effects. So they actually have bleeding in the case of CVT. So you would think, should I actually give an anticoagulant to a patient who's having a bleeding complication from the CVT? And a Cochrane review recently said, yes, it's still considered safe to give even in bleeding. But that makes me nervous. So all these patients you're going to admit. All these patients are going to get admitted. They're going to have neurology consultation and monitoring because this just sounds a little scary. A lot of these patients actually do have seizures, about 30 to 50%. So if they seize, give them IV benzos as you would, and then you want to treat the underlying cause eventually. So whatever's causing their hypercoagulable state, obviously you want to treat that. All these patients are going to get admitted again and talk to neurology or neurosurgery colleagues. So the take home for CVT is patient with a headache plus a hypercoagulable state. Remember, good history, great physical, and they may have neurological symptoms. You gotta think about this diagnosis. Really remember to do a great neurological exam, including ideally papilledema, field cuts, and cranial nerves. The test of choice is going to be an MR venogram or a CT venogram, and the treatment, it's a DVT of the brain, so you're going to give them heparin or low molecular weight heparin, and all of them are going to be admitted with neurology consultation. So I want to give you a few resources because there is so much more we could talk about in regard to headache in the emergency department. This is a great article by my friends Ryan Ram and Raman Tabatabai. This is actually chosen as one of the LLSA articles for 2023. So if you're in the US and you do your maintenance of certification, you should read this article anyways because it's in the LLSA. But they go over lots of detail about many different diagnoses for acute headaches. This is also a great review article evaluating thunderclap headache, and I just want to show you this flow sheet because it's going to bring home some of the concepts we talked about. So patient comes in, reaching for the gallon of milk, thunderclap headache. What do? First, you're going to do the non-contrast brain CT. If it's positive, you're going to treat what you find. If it's negative, you're going to ask yourself, is it within 6 hours and are they neurologically intact? Well, then good. We've excluded subarachnoid hemorrhage because of the 6-hour rule. But don't forget, there are other things that can cause thunderclap headaches. So survey for other etiologies. Super important. Remember, think about RCVS. Now, if they're greater than 6 hours from the ictus, you gotta do something else. And the something else can be an LP or a CT angiogram. This article recommends CT angiogram, probably because of what we've talked about, including looking for RCVS or vascular dissection. But if you're worried about meningitis or another reason to have meningismus, remember meningismus is caused by subarachnoid, you can also do your LP. And remember, the AHA really does recommend doing the LP. This is Dr. Edlow's article to remind you to think about all the other things that can cause thunderclap headache. And let's summarize. For subarachnoid hemorrhage, if your patient comes in and they fail the Ottawa subarachnoid rule, you gotta work this up. 6 things, and if you get any of those things, then you have got to work up subarachnoid. If you have a subarachnoid, or you have a patient you're worried about subarachnoid, your CT scan within 6 hours, the 6-hour rule is endorsed by the AHA and ASAP, and it is very, very sensitive to rule out subarachnoid hemorrhage. If your patient comes in after 6 hours, however, and you're worried about subarachnoid hemorrhage, you got to do something else. The something else could be an LP, or a CT angiogram, potentially an MRI, because you're thinking about what else could be going on and you're using shared decision-making with your patient. RCVS stands for reversible cerebral vasoconstriction syndrome. What I want you to remember here is it's recurrent thunderclap headaches that are triggered by something like exertion or vasoactive drugs. The test of choice here is also a CT angiogram. And you could also do an MR angiogram, but I want you to be thinking about this in your patients with thunderclap headache. And then finally, CVT is a cerebral venous thrombosis. That is a DVT of the brain. You're going to think about this in a patient with headache and a hypercoagulable state. You're going to do an MRV or a CT venogram to look for this diagnosis and treat them with anticoagulation. I've had so much fun talking through the differential of headache with you today. I hope you have a lot of fun in your next shift. And remember, your thunderclap headache could be a subarachnoid or something else. Thank you so much for your time today. Here's my email. You're welcome to email me with any questions or comments. Have a wonderful day.